So for those who don't know, this is Kate. She volunteers with us on Friday afternoons and Saturday mornings for the second class. And then she will go ahead and talk more about who she is, and then we'll share screen, okay?
Okay. Hi everyone, I'm Kate. I am a local speech language pathologist or speech therapist at a nursing home, skilled nursing facility in Charlottesville. I moved here a little over a year ago from upstate New York and worked with kids a little, but mostly have worked with adults and really enjoy it. So we can start whenever. Okay, so I am certified in Speak Out, which is a Parkinson's voice program, as well as McNeil dysphagia therapy. So that is related to our swallowing. The term speech language pathologist or speech therapist is very misleading. A lot of people are like, my speech is fine, or I can talk clear, but we do a lot more. Specifically with people with Parkinson's, we work with voice. So vocal quality and vocal loudness. We do speech, so clarity of speech, articulation, intelligibility, and then swallowing. The medical term, which you might hear, is dysphagia, and cognition. So that is anything related to our judgment, memory, orientation, anything with the brain. And then we do augmentative and alternative communication, or AAC. So Stephen Hawking uses a device to communicate. That is an option, especially if the patient is talking too low, but cognitively can handle a device. And general language, formulating sentences, finding words, we also work on. So specifically for Parkinson's speech and voice, the formal term is what's called hypokinetic dysarthria, and it is a motor speech disorder. So people with Parkinson's typically develop this, but not all of them fit that box. Some signs are reduced vocal loudness, rapid rate, or short rushes of speech. So instead of a nice even pace, I might talk like that, right? I might have difficulty starting it, which is difficulty of initiation, and rush. Patients might complain that their lips feel stiff, so really hard to move your mouth. And again, that difficulty of initiation, so hard to get speech started. You might hear that from someone. And you might just hear unclear sounds or words or occasional stuttering. And the stuttering is caused by that difficult initiation. So sometimes you might also notice drooling and changes in your speech with your med cycle, right? So you just took your meds, they're fresh in your system, your speech might be really loud, really clear, and as your meds wear off, your speech might diminish, become less clear, your voice might become quieter. And then you might notice mono pitch or mono loudness, meaning there's no cadence to a speech, right? There's no varying degrees of loudness. You're either all really quiet or right, really loud. And you also just might have difficulty with reduced phonation. So the ability to hold, for as long as you can, and respiration, which is the breathing. So as we breathe and talk, right, we talk on the exhale. So that coordination and breath support might be diminished. You also might notice changes in vocal quality. So it might become harsh or breathy, right? Again, that lack of respiration or difficulty with breathing. Some treatment strategies in order to increase our specifically respiratory system right now is inspiratory and expiratory training. So The first device here is the green EMST, which is just a resistive device. So you can twist the resistance and the adjustment depending on how much resistance a patient needs, and a patient would blow into that. The more resistance, right, the harder it works your lungs, and there's a whole set of exercises you would do with that. The top device here, that you might see in a hospital is an inhalation device, right? So you'll inhale and you'll try to move the little blue thing as however high that you're told to move it. And that works on the inspiration muscles. And then if you're at home and you want to work on this, balloons are really good, or straws, right? So you can blow a balloon up as big as you can, either take really long breaths and try to blow it up that way. And then the straw, you'll hold the straw and you can blow into it really slow and controlled exhales. And you could do some exercises just to keep your lungs strong. Some other speech and voice treatments are Speak Out, which is a certification that I have for Parkinson's or other neurological disorders. And this focuses on speaking with intent. So it also adds a cognitive piece to it. So you have a set of exercises to do at a certain loudness level, and it'll tell you there's a book that you do every day. You'll have individual therapy sessions as well as a group session with other people who are partaking in the program. LSVT Loud is also another Parkinson's voice program, and this focuses on increasing loudness. So Speak Out is speaking with intent. So that's the cognitive piece of thinking what you're going to say, make it functional, make it loud. LSVT Loud just focuses on increasing that loudness in general. There is LSVT Big, which is a conjunction to LSVT Loud, and that's done by a physical therapist or occupational therapist. And that focuses on like exaggerated movements. So you can always look into that. I know Sarah has probably told many of you to make your movements bigger, right? Big punches. So that is the basis of that. Some other options are Botox. So Botox injections have been shown to reduce the muscle stiffness and tremors of your vocal cords, which reduces that shakiness in the voice and hopefully increases your vocal loudness because that shakiness is reduced. Deep brain stimulation, which I'm sure everyone has heard of. This has honestly been shown to produce mixed results in people's voice and speech qualities. Research has shown that, well, depends on the person, but depends on the placement of the DBS, and also sometimes people's speech post-surgery will be super clear, noticed improvement, and then that improvement disappears. Other people have been noted to have that improvement and it's maintained. Other people have been noticed to have actually worse speech after the implant, but better results with other non-speech symptoms. So the motor symptoms have diminished, but the speech has reduced post DBS. Some things you can do at home if you are a caregiver or even the individual with Parkinson's is you can use a pacing strategy. So you can use a pacing board or any type of cardboard, anything that you can draw lines, vertical lines on, and have them tap each space. And you could say, I need help. You can also do the same thing with clapping your hands together or even tapping the table. You could do it together with your caregiver, or the caregiver can prompt it, or just the individual can do it as well. It helps increase your clarity of speech by pacing you, because when people talk in the short rushes, it's harder to understand. Again, the AAC, so the devices, I have one here This is just an example, but it basically like is a little tablet.
Can you guys see that? Thumbs up if you can.
If you can see that, thumbs up.
Okay.
Okay. Yeah, so it's a little tablet. And again, if you like cognitively can navigate it, it's great. You can customize it any way you want. So like this one only has like 3, and you would click like
My restaurants.
and then it speaks. So just like how Stephen Hawking's uses a device, this is similar. You can also use like a picture board. So if you print out a picture of a bunch of different things, right, and have them point to, oh, you need water, or have them point to the bathroom, right? That can also be a way to help bridge that communication gap if you can't understand them. Some general clear speech strategies. So as caregivers or individuals with Parkinson's, you can think about either cueing or doing, really moving your mouth. So over articulating, which helps with clear speech. Taking a break. If you feel like you're short of breath, tell the person, slow down, take a break, we'll come back to it, right? Or take one big breath and break it up. And then the last thing is an amplification device. So any microphone or headset or anything that can help amplify without them physically having to yell could also be really helpful. How many of you, if you put your hands up, have like a smartphone? If your camera's off, that's okay. Yeah. So a decibel reader on your smartphone, there's a bunch of different free apps out there, is really, really helpful with giving that feedback of how loud either you or your partner is talking. The average conversation is about 68 decibels. So if you put the phone near you, right, you can cue the person and say, try to hit 70, right? And then that's a great visual feedback for them to see, like, are they talking loud enough? And you can work on that. So in addition to speech and voice, we also do the cognitive piece, as I mentioned. So neuroplasticity itself is the ability of the brain to adapt its structure and function throughout life. So, we get sick or we have, hold on, should I check? If you just search decibel reader in the app store, there's a bunch of different free ones. I don't have a particular one that I recommend. But if you just search, I'll type it. Decibel meter or reader in the app store. And if you find a free one that you like, try them out. I hope that was helpful. Okay. And then, so back to neuroplasticity. So, right, sometimes we get sick, or sometimes, a hospital sets us back, or anything that might set us back a little and we feel a little foggy. The ability to regain or feel less foggy, right? Our brain's adaptation is neuroplasticity. So in order to either prevent and slow cognitive decline and gain back those skills, really good sleep is important. Just like general brain health, eating a healthy diet is also super important to keep that brain clear, and cognitive games. So Wordle, crosswords, Sudoku, things like that, or even just like word finds. I also I like to play a lot of games with my patients, whether it's even something as simple as war that involves what I call working memory and just decision making, right? Your mind's always thinking in those games. Any type of game. Being social is really important. I know there's a good community here, but getting out of your house or having friends and family over if you can't leave your house. It's like stay social, because socialization has been shown to slow cognitive decline. and then working out as well. So coming to class or hitting the gym or, doing stuff at home, whatever you need to do just to get up and moving has also been helpful with your brain. So bradyphrenia itself is like the medical term or professional term of slowness of thought. So people with Parkinson's, they might need extra processing time, right? So sometimes repeating yourself doesn't help. They know what they know what they were asked. They just need a second to process. Sometimes repeating does help. The cognitive declines in people with Parkinson's have been noted in working memory, which is like your instant memory, planning, attention, the basal ganglia, which is also the part of Parkinson's, but trial and error learning and internal cueing, the basal ganglia plays a huge role in. It's basically like the reward center of the brain. So, right, it's the acknowledgement of, oh, I did that right. It made me feel good. I can do it again. Or, oh, I didn't do that right. You know what? I don't feel great. I won't do that again. So people with impairments in that internal cueing is the lack of insight. So sometimes caregivers can cue those people and say, hey, like, was that safe, right? Bring their awareness to it. If you would like, you can either type in the chat or unmute or just unmute yourself and guess what age human memory starts to decline. I want at least one guess if there is one guess.
You guys should be able to unmute yourselves. If not,
If not, that's okay.
you can put your fingers up.
Yeah.
too.
I'd say 24.
Okay. It is 25. So that was pretty good, Aaron. Good job. Yeah, so just sorry. So just in general, people think it's much older, but it really isn't. 40 was close too. A lot of people say 60 or 70. So just in general, our memory starts to go at 25. So as a speech therapist, we do a lot of cognitive treatments, memory tasks. So we have short and long-term memory. We have more memories, but those are the gist. Basically, our memory in our brain is like a box. The box does not grow with the more memories that we have. So it can only fit so much. The reason why you probably feel or notice long-term memories are more preserved than short-term is because that is true. And long-term memories, every time you recall a long-term memory or remember it or talk about it, whatever you do, it makes another copy in that brain. So if you are talking about a childhood memory from when you were 5 and you've talked about it 200 times, you have 200 copies. But short-term memory, if I told you something yesterday and you only thought about it once, you only have 1 copy. So that's why you're more likely to remember long-term. So we do a lot of memory tasks to even just maintain our skills we have. We do attention tasks, and there's 4 types of attention. I won't forget one like I did last time. So we have selective attention, which is the ability to eliminate unwanted stimuli, right? So if we're in a crowded room and we're trying to do one thing, make a phone call, and someone's talking to you, it's your ability to prioritize that phone call. Sustained attention is just focusing on one thing. So you're sitting down to pay just your bills. Nothing else is distracting you. You're just doing that one thing. Divided attention, so that is driving, right? You're out driving and you have a lot of distractions going on, but you have to pay attention to everything. You divide your attention, and alternating is being able to switch from one to the other. So if I was cooking dinner and then I went to watch TV, Then I went back to cooking dinner. So just alternating between those two. So we do a lot. I know Sarah does the cognitive class and also some cognitive stations in class. And that a lot of that also works on attention and memory. We also work with problem solving. So a lot of times, right, patients come to me because I work in a skilled nursing facility. It's a temporary residence for them. So I work on getting them home at the safest and most independent level, right? So I do a lot of problem solving where I might ask you or present you scenarios that you find in your house, like what would you do if there was smoke in your kitchen, right? And I want to make sure that patients can answer that or they have caregivers present. Compensatory strategies. So a lot of cognitive compensatory strategies involve caregivers. So making environmental aids, whether that's a visual note like a to-do list or a calendar, a verbal reminder to help reduce that forgetfulness. If you notice that, if you feel like someone is keeps forgetting, oh, my grandkid, did they come? Did they visit? Or, you don't want them to forget, get a calendar out, write down, Joe was here March 9th, right? So that helps them and refer them back. Orientation tasks and word finding difficulty is also what we work on. So word finding difficulty, so there's anomia, which is just the forgetfulness of a word. You might know what it is you want to say, but you're not able to say that word. So as a caregiver, what you can do is have the person describe it, right? Describe the feature. So if I was trying to describe this towel, I would say maybe where it was found. You find it at the bathroom and it's soft, and what do you use it for? And if, they're unable to gather the word from that, you can give them a letter cue or a sound cue, right? You could say it starts with the letter T or it starts with a T sound, and that might help also with that word finding, because sometimes people get more frustrated when they can't find the words to communicate. In general, we have dysphagia, and this is the last piece, but it's a big piece. I feel that's most important because it is medical. Dysphagia itself is just difficulty swallowing. So whether it's the incoordination or the muscles, you just can't swallow food, drink, anything, saliva. There's 4 stages of the swallow. So the oral prep phase, the oral phase, the pharyngeal phase, and the esophageal phase. So the oral prep phase is like the brain sending the signals that a meal is happening. So me sitting down at a table and knowing, oh, I need to bring the utensil to my mouth, right? It's everything before the food enters my mouth. The oral phase is anything that happens in the mouth, right? So the chewing, the holding of the food, anything like that, the moving of the food. Pharyngeal phase is from the mouth down, like the initial swallow in our throat. And then our esophageal phase is when the food goes into the esophagus to our gastroenterology system. Basically what happens is, and the goal of speech therapy for dysphagia or swallowing is to minimize aspiration or the risk of aspiration pneumonia. So we have our trachea and our esophagus, and when we swallow, we have the epiglottis here. When we swallow, the epiglottis should cover that trachea, which is our windpipe, right? If that epiglottis doesn't work, right, our food or drink that goes into our trachea can go into our lungs, which could lead to aspiration pneumonia. I'm not saying it will one way or another. I don't have a crystal ball, but we want to minimize that risk, and there are ways to do it. So in individuals with Parkinson's, some common signs and symptoms of dysphagia are impaired perception. So that is anything from our body recognizing oh, we have to swallow this, or me eating, do I eat a large chunk of meat or am I eating small pieces of meat, right? The larger the bites, the higher the risk of aspiration. Another thing that's noted is the impaired breathing and swallowing coordination. So when we swallow, we want that epiglottis to cover that trachea. When it's open, like I said, or if we inhale and swallow, right, that's when food goes down the wrong way. We might notice an impaired cough. So you might hear, if you're a caregiver, right, you might notice it or hear it. It might sound weak. It might just sound really quiet or just breathy. We want a strong cough as if you or I would be coughing. And we also might just notice reduced neurological coordination and control. So sometimes food will go down our throat before we're ready, right before our brain responds and our body's ready. Sometimes we just might not realize food is sitting there, or we won't be able to bring it back to our throat. And then the other thing, especially with people with Parkinson's, is there's a reduction in substance P, which is just a neurotransmitter that transmits the signals from your sensory nerves to your central nervous system. So that reduction in that neurotransmitter is diminishing the message that's sent to you that says, hey, I'm eating, I have to swallow this, I have to put it to my mouth. Everything that the brain tells the body to do is just slower or diminished. And that also leads to your cough and swallow dysfunction. So the lower the substance P is, usually the weaker or more impaired your cough and swallow is. Our main goal as speech therapists is to minimize your aspiration risk and be able to still meet your primary nutritional and hydration needs. So a big part of our lives as humans is eating, right? You throw a party at your house, a lot of people come and eat. I know I eat a lot. But you go out to eat, right? There's banquets, there's even pancakes for Parkinson's, right? That's all, we are so centered around eating that sometimes if you're eating modified food, whether it's pureed or chopped or anything like that, it's not always appetizing, nor do you want to eat in front of everyone. A lot of times too, sometimes with the modified food, which we'll get into, is it's just not appetizing. People don't want to eat pureed food, so then they're not eating. But it's more important to eat, right? To maintain your weight, to maintain your health, than risk aspiration. I don't have a crystal ball one way or another, but I know people who have been a high aspiration risk and have never aspirated or got pneumonia from it, and they lived another 20, 30 years, whatever, right? I know people who have had a fluke and who have aspirated or developed pneumonia from it, and they didn't even, it was just a fluke coincidence. I don't have a crystal ball, but we want to focus on finding a balance between those. So as a caregiver or individual with Parkinson's, some things to look for during meals is in the oral phase. So anything that's in your mouth is impaired oral bolus, and bolus is just the term for the chunk of food once it's in your mouth. So whether they're unable to clear it, meaning swallow it, whether they're chipmunking, pocketing, right? Whether you feel like it's all on one side or it's just sitting there, you might notice that. Another thing is impaired mastication, so chewing, right? If you're sitting there at the dinner table and it's like taking forever for them to chew their food, that's another risk for aspiration, but also a sign to maybe talk to your doctor or ask for a speech therapy referral, because there are strategies to reduce that. Tongue pumping is just if you see their tongue coming out and they're trying to propel the food back, that's another sign. Any residue is a sign as well. So if they swallow and there's still just like some residue on your tongue, even if it is like mostly gone, and drooling is also a big sign. Pharyngeal phase, so from the back of the mouth, basically right down the swallow, anything to look for is a reduced cough response. So whether it's a weak cough or you feel like if they say like it went down the wrong way, but they're not coughing, right? Something that we might cough on, you might want to look for that. And if they're not really reacting or their cough is weak, that's another red flag. A delayed swallow response, right? So again, if the food is already chewed up, typically we would just swallow it. They might hold it, and you might have to point out like, swallow your food, right? Or you might have to like say like, can you feel that food in there? And then, sometimes get them thinking about it again to swallow. A lot of times with people with Parkinson's, sometimes the food goes back down, into our throat before we're ready to swallow it. So then our body's not prepared. Sometimes with that delayed swallow response, if you're like holding it, you can, as a caregiver, present a utensil to their mouth to, get the 4 stages of the swallow going again. And then in general, just reduced pharyngeal motility. So the ability of the muscles to move a lot or a little, right? That's all reduced. The strength of those muscles can diminish as well, which impacts the ability to swallow harder things. Sometimes starchy things get people, so breads, pastas, things like that. So also pay attention to, is it just certain foods? Does it seem to be everything I'm swallowing? And discuss that with your doctor. Some general strategies that we as speech therapists give, we can give swallowing exercises. So maintaining your swallow muscles is really important. So things like I might tell a patient, take 10 sips of water one at a time, right? And each swallow, try to swallow really, really hard. Rice is rice is a big food that is aspirated. Little bits of stuff, right? Like the rice can be dry, for people who saw the chat. Things that are dry and individual, right? A piece of rice can easily go into your lungs versus just like a piece of chicken or something, or moist. If you do notice you're aspirating on rice itself or anything like that, add gravy or add a broth, something to like moisten it a little bit if it's super dry. If not, you can just avoid it or go to a therapist for treatment strategies if you really like rice that much and want to keep eating it. Another swallow exercise is like what I call a chin tuck against resistance.
I don't know if they can see you or not. We'll just
They
try.
can see me. Can you guys see me? Can you get a thumbs up if you can see me? Okay. So as a caregiver, you can either take your fist and put it under someone's neck, right here on their chin, or you can just have the patient do it themselves and with a towel, and you can have them hold the towel or whatever you need to use, washcloth, anything, with their chin for like 30, 45 seconds at a time, a couple reps a day. I like to do like 2 sets. And of course with the fist, the more resistance, the more muscles you use, because we at least want to maintain that, especially if we notice swallowing changes. There's more, and I'll send out a list of things regarding the exercises. The environmental modifications. So this is a big one, especially for caregivers. Are they getting distracted by the TV, or does the TV help them? And do they just swallow when they're watching TV? If you feel like it's too loud or distracting, or you want the lights on or whatever, all of that plays a role in people's mealtime and swallow. caregiver cues and postural modifications, right? So as a caregiver, right, you can verbally tell them, swallow, right? Take small bites, take small sips. You can alternate between small bites and sips, or you can tell them with tactile cues, you can shake your finger and just like drag it along from their mouth down. You can touch their throat, anything to get them maybe to swallow or feel that. Diet modification, like I said, we can go into, which is just modifying consistency of food and drink, and just general safe swallow strategies. So take smaller bites, alternate a bite of solid with a sip of liquid to clear that all down and make sure it's down, right? Take 2 swallows each bite if you need anything to get you to safely swallow. Sitting upright is always a big one, right? Try not to sit hunched over. Sitting up in a chair versus in bed or on the couch is always great. And staying upright after meals can reduce the risk of aspiration as well, because if you eat and then lay down, you can still aspirate because you can regurgitate it. Diet modification. So this is huge. Okay. Diet modification is huge. So there's 2 different systems depending on the facility, like a hospital or wherever you go, if you go for speech therapy. So IDSI, this is IDSI, which is a 6-level consistency. So if you hear these terms, the first one is regular, which is what we eat, solid food, right? A regular solid chicken breast, a hamburger, anything like that. The next level is level 6, which is soft and bite-sized. And that is the chicken breast, but it comes cut up, right? So if you, as the individual, cannot cut it up, make sure your caregiver cuts it up or ask them to cut it up, right? Or if you notice someone doesn't seem to do well when they're feeding themselves and they're being given a whole chicken breast, you can try to cut it up and see if that helps. If you still notice some difficulty, or you hear, you can try minced and moist. Again, a speech therapist might also recommend this, and that looks like ground beef. So everything would come kind of ground up. And then pureed, which is everything's pureed. So butternut squash consistency, I like to say, or, a little thicker, mashed potatoes, stuff like that. And then fully liquidized is just liquid, mostly drinks, then liquid stuff like that. With drinks, with the IDSI, we have more levels, but basically we have on the upper right corner with the thick and easy, where it says honey consistency, those come in individual packets, and those are already pre-thickened liquids. They have water, they have juice thickened, you can thicken coffee. And then in the bottom right with the thicket, that is just a powder you can buy at Walgreens or CVS, wherever you go, and you can add it to whatever you need thickened. And each consistency requires more or less thickener. And the bottle tells you, again, a speech therapist would also tell you. So the first level of liquids is just thin liquids. So that's regular water, right? Easily spills, pours, whatever. The next thick is mildly thick or nectar. And that is just slightly thicker, but it still pretty easily comes off a spoon. The third thickness level is moderate or honey thick, which is, picture what honey looks like. It would take a little longer to run off a spoon. It would be thicker in your mouth. The fourth one is like extremely thick or pudding thick. So that, picture pudding, right? Like that is what you would be drinking, is a pudding consistency. The trick about thickened liquids in general is sometimes the thicker the liquid, the fuller you feel. So, right, you might not eat as much because you might feel fuller. And then also, if you are aspirating on thick and thin liquids, sometimes it's better to stay on thin liquids because the more volume that goes into your lungs is the higher risk of aspiration pneumonia, just because there's so much more in your lungs than there would be on thin. NDD, this over here is just another term for a modified diet. So with this one, there's only 4 levels. And if you hear, you might hear a speech therapist or hospital or doctors say regular, dysphagia, advanced, mechanically altered, or puree. So there's less wiggle room with this one, but if you see these terms, that is what that's referring to. Just some general things to consider is, right, outweighing nutrition and hydration risk versus or lack of and risk of aspiration. So like I mentioned before, you can live if you are at an aspiration risk or aspirating, but you can't live if you're just not meeting your nutritional and hydration needs, right? So focus quality of life and finding a good balance and working with your therapist, working with your doctors, modifying certain foods, right? Avoiding certain foods, rice being one of them. Getting a swallow study. So I don't know if anyone has gotten one on here. But there are 2 different ones. So a modified barium swallow they're both, I would say, non-invasive. Is done in radiology, and you sit down and they give you a bunch of different consistencies, but it just has barium, either barium paste or barium in the drinks. And then the x-ray shows how your food is going down to see if you are choking or if there is dysfunction. And then the fees, which is just a flexible camera that can go up your nose, and it just goes to like right here, so you can see people's vocal cords and see when they swallow. It just provides a different view, and not everyone qualifies for one or the other, just depends on insurance and wherever you go. But I would definitely, if you have concerns, ask for a video swallow or a swallow study to make sure you can see what's going on, because we can only see so much. And there is a thing as well called silent aspiration, which means you could be aspirating and there's no signs at all. So a lot of times without it, the question was, is it good to get a baseline? So a lot of times, if you're not displaying signs or symptoms, or you don't have, or caregivers or people don't have concerns, insurance won't necessarily pay for it. So, you could always ask just to see, but there's no harm in getting a baseline. We do a lot of bedside stuff too, right? Which is just me sitting there watching you to make sure. But unless you have concerns, in my opinion, it's not worth super bringing up, but baselines are always beneficial. And then, oops, sorry. And then you want to think about get a productive cough. So, right, someone might be eating, and if you're sitting at dinner, and they're coughing a lot, it's not always a sign that things are going into their lungs. It's just, it could be good because your body's responding and it's able to clear your lungs. So sometimes a productive cough is not always bad. And then just some signs to look out for of aspiration and aspiration pneumonia are watery eyes, nasal regurgitation. So when eating, if you need to blow your nose a lot, if your eyes are watering, coughing, throat clearing, and wet vocal quality. If a person sounds like they're drowning or their vocal quality changes at all when they're eating, not great. Pneumonia signs, chest pain, fever, shortness of breath, lethargy, smelly breath, and confusion, all signs caregivers or people should look out for that pneumonia could have developed. Another thing is, if you have like a pulse ox at home, you can always put it on. And Erin, like, this might be helpful for you if you're a caregiver or whatever. You can put it on your finger while you eat. And if you see a dip in the oxygen level, that could also be a sign that there's aspiration when eating. Just general vocal hygiene tips, right, to help amplify and clear your clear your voice is good breath support, manage acid reflux, avoid caffeine or, things that dehydrate you. Try not to scream, right? Like if you feel like you're not loud enough, don't try to relax those muscles. The tension doesn't help, and rest your voice as needed. I will stop there, and that's the end anyway. For any other questions?
Please feel free to
Oh,
unmute.
he has a question. Yeah, you can unmute or whatever you need.
Okay, do you know of any research on the possible benefits of singing with articulating and controlling your breath and loudness?
Yeah, so sometimes I will do some singing stuff. Because we call it, even though it is singing, sometimes it's connected speech / automatic speech tasks. It's never a bad thing as long as you are practicing good vocal hygiene, right? If you're not straining while singing, because it builds that respiratory system.
Mm-hmm.
Yeah, and then Sarah actually had
I need more to wine too.
Sarah
Hey,
had this one
You're a hard
person.
person to be whatever it is.
Sorry.
Who's that person who reached out to you with that singing program?
So yeah, there's an app that we're looking at potentially trying here at the gym, and it's available for like one-on-one or for group training. And it's not karaoke per se, but it kind of like preps you for singing. So we're looking into it. I can't quite remember what the name of it
Yeah,
is. I think
not
it's
to
called
put you on the spot.
Sing Fit, I think is what it's called. But we're potentially trying to get it tested here at the park.
I would think doing rounds like row your boat. That would be fun to do with a group.
Yeah.
I'll
So
add it to class tomorrow, Jim.
only for you. You have to do all the rounds. The other thing that's nice, like some of the speech exercises I do and Speak Out does, or LSVT, those Parkinson's programs, are pitch glides. Because it just gets your vocal folds moving as well, your vocal cords, and that also works on breath rate. So if you can do if you could do it in one breath, that's great. If you need to break it up after you reach the high part, you can break it up as well.
Mhm.
Does that answer your question?
Yeah.
Okay. Do they have a question? I don't know their name.
Diane, do you have a question?
No, I'm good, thank you.
Okay. It's just because you unmuted yourself, and so we just wanted to make.
Oh,
sure.
yes.
Oh, a pitch
We were trying
glide.
to figure out how to mute and unmute, but this is our first time doing it.
But we're good now.
Okay.
We'll go back to you now that we know how to do it.
A pitch glide is basically like a singer would do for warm up, where you start like low and high. So you would go, ah, and then if you need that break, you would go high to low. So you would go, ah. If you could do it all in one, that also works. I don't know if you heard me. I hope I was loud enough.
Yeah, I heard you.
Okay.
Thanks.
Yeah.
A question got brought up during the in-person session was, what strategies does Kate suggest on if someone has to take a lot of pills? And it's the first pill was fine, second pill a little bit slower, third pill really slow, and then fourth pill takes 4 times the length of the first pill.
Yeah. So with that, I don't know. This is like what I have discovered through my career and also just reading. Multiple things you can do, right? You can lessen the strain of the swallow. So if you have pills that can be crushed, crush them and then put them in what we call masking. So applesauce, yogurt, pudding, ice cream, anything like that. And then alternate that. And you can also prioritize your meds, right? If you really need your Parkinson's med, right? Or if you really need your high blood pressure med, try to take that first or take the big one. If you think you could live without your vitamin D for one dose, right? And you can't get that down, maybe save that at the end or take a break. But yeah, and if you have super big pills that you can't crush, maybe talk to your doctor and see if there's a generic brand or a different pill that's smaller or crushable to help lessen that load.
Anybody else have questions? John, are you trying to unmute?
Yeah, I think so. We can't hear. You can do it. The other thing while John's unmuting is oral hygiene is just super important, especially people with higher aspiration risk. We always recommend brushing before and after each meal. If not, just general 2 times a day. If you don't have the dexterity, what's her name?
Yeah, so, someone brought it up. Ugh.
Yeah, brought up the auto brush, AUTO brush. And you just pop it in your mouth and it comes with like a foamy toothpaste that it just brushes for you. But yes, even if you don't have teeth, if you have just dentures, brush your gums, brush your tongue, everything just to lower that risk of infection and aspiration pneumonia.
I think just charging it.
Okay.
We have about 8 more minutes. So if you do have questions, feel free to put it in the chat. Feel free to unmute yourself.
Sarah, you had mentioned there's a local group around here that sings, like it's a Parkinson singing group or,
Yes, let me go grab that.
okay.
I
Oh.
don't know if they still meet or not, but I have that information somewhere.
No, we don't know. I've seen that.
John and Brenda would actually have that answer on whether or not they still meet because their daughter runs it. So it's called, I haven't had, not 100% confirmed that it's still going on, but it's called Movers and Shakers. And that is on the second Wednesday of each month at the Church of Our Savior, which is on Rio Road. And it's for people with Parkinson's. That's what Aaron was talking about.
Thank
John
you.
is
Yeah.
John, is Bridget still doing that?
Yeah, she is still doing that.
Okay.
She did it last Wednesday.
It was last Wednesday. Yeah, because
Yeah.
today's the third Tuesday.
Okay.
Yeah. They don't have to sign up. They can just show up, right?
That's right.
Yeah.
And Bridget is an opera singer and teaches at PVCC. Is that correct? Or
Yeah.
UVA?
UVA and
That
James
UVA
Madison.
too.
Wow. Does anyone have any other questions
I
or any?
This is Diane. I don't really have a problem eating, but what happens to me is I'll just be sitting here randomly and it's like, oh, there's a liquid in my mouth. And next thing you know, I'm choking. Is that part of Parkinson's or is that something different?
Yeah, that is so what we call secretion management. So we all collect saliva and our brain subconsciously does that on our own, right? So sometimes if you feel like you're choking or, that's pulling up, like swallow that. So bring awareness to that if you can, right? Every so often swallow, even if you feel like you don't need to reduce that collection of saliva.
Okay. But
Was
there's
that?
really
Oh,
there's
go
nothing
ahead.
you can do to prevent it. It's just once you're there, you have to swallow. And
Yeah,
that's when I swallow.
So there's,
Can you repeat that? Sorry.
I said, it seems to me that when I start to swallow is when I start choking.
So I would mention that and see if the speech therapist or neurologist can refer you to a speech therapist for even just strategies on that.
Okay.
Yeah. Try to tuck your chin during that swallow.
Oh, okay.
That might help you, but again, if you want more in depth, either you could reach out to me or talk to your doctor.
Okay. Very
Okay.
good. Thank you. Not my imagination then.
So the question in the chat is, do all Parkinson's patients have speech and eating disorders? At what stage of the PD does this occur? So based on the continuing eds and research that I found regarding like the swallowing disorder, I've seen 80% of people with Parkinson's have mentioned some sort of difficulty swallowing. Now, that doesn't mean everyone is on a modified diet, and that doesn't mean people can't swallow. It's just even what Diane said, like occasionally I feel like that saliva is choking me, right? That doesn't mean, and then the speech concerns, I'm not going to say everyone with Parkinson's has both because everyone presents so differently, but it is typical for people with Parkinson's to develop some sort of speech disorder. That's usually earlier on, right? You'll notice a change in your voice, whether it's even just the ability to be as loud as you used to. But it, again, all depends on the person. I've noticed people who have had Parkinson's 30, 40 years and are still eating solid food. And then I've had people who have had it for 5 years and I'm trying just to work on them eating just little bits of pureed. So it all depends. How long does it take to learn sign language? I took it for 3 semesters and I have forgotten most of it. That's why these communication devices are helpful. Because in my opinion, they can be pretty quick to learn, and even just a picture board can be helpful, or writing and anything that can help with that communication. If you want to learn sign language, you can try. That's a good cognitive challenge. But it's not, sign language isn't universal. That's the tricky thing too, is then your caregivers would have to learn, and right, you're limited in that. Does anyone have any other questions? I thought I saw a hand or something.
We got about 2 minutes.
No. Was this helpful?
Yes.
Okay.
What we'll do is we will send out the recording once we gather some additional stuff that Kate wants to provide to you all, as well as her contact information. Also probably the link to that toothbrush that was mentioned.
And maybe info on the singing group.
Yeah, singing group as well. We'll get that out in the next couple of days or so.
Thank you.
You're
Absolutely.
welcome.
This was wonderful.
Yeah,
And
really
it's
helpful.
So easy and understandable.
Good. Feel free
Very
to reach out with
practical. It was good.
more
Yes,
specific.
I'm especially thankful for the term oral bolus management. I'm going to try to work that into my conversations.
Hey, Jim, just don't add,
He's a name dropper.
Jim, just don't add mastication too many times.
Okay.
Thank you.
You're welcome.
Thanks,
Thank
y'all.
you.
All right, please feel free to reach out. You guys have our info at the park. If you have questions, and then once Kate gets all of the information together, we'll send it all out with the recording of this Zoom.
Thank you.
Okay, thank you.
Lots
Thank
of-
you, Kate.
It was nice meeting you.
You're welcome.
Yes.
Thank you.
All right, bye,
Thank
y'all.
you.
Bye. Thank you.